Okay.
Okay.
Okay, today is November 25th. Finance Committee called to order at 9 o'clock on the 25th. And so are there any changes to the agenda? Can everybody hear me?
Yeah. Yeah. I don't have any changes, Gene, so I'm good with having the agenda approved as distributed.
No changes.
Okay. No changes? Okay. Approval of the minutes. Need a motion?
They look good to me, Gene, so I'll make a motion to approve the agenda.
Okay.
I mean, the
Minutes.
sorry.
Okay.
I'll second those.
Okay, so the minutes are approved. Public comments, there's no public here. I'm not gonna read, everybody else seems to read that, but if anybody wants to say anything at this point. Financial statement, that would be Barbara.
Starting, yes. So we're reporting on the month of October. And if we go to page 17 first in the packet, is the volumes for the month. And about the middle of the page is the average daily census on acute. The total was 5.5, 3.0 for acute, and 2.5 for swing beds. Year to date, the acute's at 4, and the swing beds are 3.4. And in the prior year, the total was 6, whereas this year we're running 7.4 on the year to date. Long-term care, they had 47.3 average daily census against a budget of 55. Same month last year, they were at 56. And currently year to date, they're at 49.6. And last year they were at 57.3. The ER this month was quite low, 478 visits for the month. Of those, they admitted 3.56%. Year to date, they're at 2,167. And last year at this time, they were at 2,504 year to date. Outpatients exceeded their monthly volume with 1,263 visits. And year to date, they're at 4,780. And the prior year, they were at 4,659. Some of that's related to the COVID visits that we are having. The clinic visits, they exceeded their budget this month by 309 visits. On the primary care, they had 1,699 patient visits. Year to date, they've had 6,473. And last year, the same period, they had 5,841. They also had specialty visits for 299 visits. And year to date, they're at 1,209 specialty visits.
Can I make a comment on that clinic visits? You guys did really good whenever you remodeled and put the money into that clinic and have been promoting it. It's really working good. Sorry.
That's okay.
Oh, thank you.
I think it's the providers they like.
You know, if that's
Where they are,
what I'm trying to do is if you can find a department that's doing well with the current volumes, and you put a lot of money into that's the whole idea. You put some of their profitability back into the department, and it even makes it better.
They're doing good in the community. They're premium. They're the best. And we want to stay there, which I don't know how we wouldn't, but it's working well. We've got a good reputation. We're looking good there.
And that helps the hospital.
Oh, well, we're all together. It's just a piece of it, but.
The nice part about the clinic is that obviously because it's a rural health clinic and under that licensure, we have to have 50% of the visits on mid-levels, not physicians, but mid-levels. You can only have 50% physicians. And what's happening now, even with doctors' offices, is they're beginning to use mid-levels in their office. So there's not really anything dramatically different than the community would get in a doctor's office. And that was just not with anything that we did dramatically or dreamed up. It just happened well.
So we need, for the emergency room, we need more rioting and stuff here probably, or something like that. We're too calm and nothing happening.
Did you just say rioting, Gene? Is
Yeah.
that what you said?
We need to get some people from Seattle to move here.
Oh, geez.
No, we
I don't
don't.
think we don't need to get that bad.
No, we just have to have a COVID scare up in Kernville. That'll do it.
Yeah. Keep the bars open, right?
The clinic also had 16 visits in the mobile van in the month of October. And I think their plan is to start using that a little bit more frequently.
We'll talk about that a little bit later in the meeting.
Yeah. Surgery, they had 6 outpatient surgeries and 46 scopes. Year to date, they've had 15 outpatient, which is exceeding last year's and their budget on the year to date. Outpatient scopes were 161, and in the prior year, they were 159. Retail pharmacy, they filled 3,303 scripts. Year to date, they filled 13,266. Not quite as much as the prior year to date of 13,000, but they're hanging in there. Are there any questions on any of the volumes?
No, I'm good, Barbara.
If not, we could go to page 12, which is the revenue and expenses.
That's 12 at the bottom.
12 at the bottom. Our total revenue for the month was $9,079,000. That's $1,271,000 under our budget target. Last year at this point, we had $9,470,000. After our deductions, we had an operating revenue of $2,215,000, $460,000 under our budget. And last year at this time, we had $2,440,000. So with our expenses throughout the month at $2,554,000, and our non-operating revenues, we ended the month with a loss of $300,265. Last year, for the same month, we'd had a profit of $131,168. Are there any questions? We did receive we had funded the prime payment a couple of months ago at $400,000, and we received the $800,000 back in the month of October. It was the prime payment.
Oh, that's the IGT, Barbara?
Yes.
Okay.
Now it's, okay, I see over there, 18, okay.
Yeah. Are there any questions on the month or comments?
Yeah, so that's basically just because the volume had been down this month, Barbara, like with the ER and those kind of services?
Yes.
Okay.
Especially where they are, because they're so they're so intensive of other services like radiology and so forth, that when they're down,
Yeah.
obviously we feel it elsewhere.
As far as the emergency room, could it be that people just don't want to come here? I mean, unless they really have to. Before they sort of use us as a doctor and market, you think maybe people are intentionally trying not to come in?
Oh, I'm sure of it. People are afraid of COVID and they don't want to come into the ER. I'm sure that.
This is, again, I had a conversation with the other CEOs the other day, and they're still experiencing the same weakness in their ERs. Their volumes are down, even at Memorial. They're down quite a bit. So it's just that everything has changed since COVID, and it's been softer. And it's just going to take a long time for us to rebuild that trust back.
Okay, everybody needs to behave if they can. Ross Elliott showed up on there.
Oh, quiet.
If there's no more questions on the month to date, we'll go over to page 12, or 13, which is your year-to-date numbers. So year-to-date, we are at a loss of $5,000 total. Prior year, for the same period, we'd had a profit of $250,956. You can see our revenues are $2 million under our budgeted target. And our expenses were under our budget also by $565,000. And so it's bringing us to an accumulation of a loss for the year to date. Are there any questions with the year to date?
No, I'm good, Barbara.
The only question I had, Barb, again, I was looking at, the big thing where we were off. I mean, obviously salaries year to date, they're up about 240,000 over prior year, which is about 5.7%. I was looking at this last night. And if you assume we had a 4% increase in salary increases, that's about a 1.7% increase there. The big thing I think that we were really off was on purchase services. It was up by 350,000. Just curious, what is in there, and you might not have that answer right now. So, but at some point, I'd love to see, where that's gone.
I'll help you with that just a little bit.
With
That
that,
has, and it doesn't have the repairs and maintenance. You see, that's over a little bit.
yeah,
So the outside work that was done on the leach field and stuff, that's not there. The majority of that purchase service is our costs from CPSI, right, Barbara?
There's a lot of cost there.
Our costs, pardon me?
There is a lot of cost in CPSI.
A lot of costs in CPSI. And other, not just CPSI, but other information systems products as well, like the LMS, okay? That's very heavy.
Yeah.
So a lot of that, it has to do with that, because the other services like laundry or basically they're staying the same. So it's the majority of the overage in CPSI is information systems products.
yeah. Can I get a listing on that, Barbara, at some point? Just of comparison of this year to last year, year to date.
In that department, we can do that.
Yeah, just in that line item. Thanks, Jeff.
Okay. We've also increased, because of the new equipments in radiology and the lab, there's added service contracts there
Yeah,
also.
right. That makes sense.
That should be repairs and maintenance, though, Barbara.
I'm not,
We're not charging it there, but if you have a service agreement, the service agreement should be repairs and maintenance, unless it's not for repairing the machine.
Yeah, but software maintenance and stuff like that, yeah.
Okay.
Thank you.
Okay, if we want to move to page 23, it's our 3-month rolling calculation on the days in the accounts receivable and the days in the accounts payable. At the end of October, the days in AR were at 74.7, and the days in the accounts payable were at 44.5. And if there's no questions, the following page, 24, is our cash collection.
Just a quick question on the AR days. Where are we at? What are the plans on obviously getting that down? I know, Chet, your goal was like 60 at some point in time, and I know we had some issues with the new system and everything else, but how is that going in terms of reducing that?
We're
Reducing
working
it
on
from 44 or reducing it?
No, from the 74 down to 60.
the AR, he means.
AR days, yeah.
We're still.
Well, you mean they're actually going up a little bit?
Yeah,
Barbara didn't want to tell you that, but it's true. I check it every week when
I
it
figured you do.
updates. And we're actually right now on the books about 80, 81.
Okay.
And
Yeah.
the majority of that, I can even tell you, is in insurance patients. It's basically, well, let me say it this way. Let's go down to the last sheet of that packet, of the first packet, and it'll tell you.
What page was that?
Does the first packet?
Page
Okay,
18.
it's page 19.
Thank you.
19.
Okay, page 19 will tell you that the days outstanding for all services is 74.29, and the target is 60. Inpatient 74.09, target is 60. Outpatient 75.36, target is 60. And long-term care, and this is the highest I've ever seen long-term care. I'm going to say that 75.60,
Yeah.
and the target is 50. Okay, you can see that unbilled for those things that were not being done on a routine basis, and when I look at that, I see it being in the in some of the coding, depending on when you look at it. I don't think the physicians are any different in their portion, doing their notes or anything than they have been, but we're running 5.4 instead of 3. Credit balances, we're okay. Self-pay, 13.78%. It's been staying in that area. Charity care, there really isn't any. Bad debts are still pretty good. You can see that.
Mhm.
The collections are absolutely excellent. In this month, for example, we collected 133%. Now, what this
Yeah.
is collecting more than 100%. Is when you get non-revenue producing. If you get money in from Prime or IGT or something, then if you're doing it right, if you're calculating it right, it should throw you over 100%. And
Yeah.
for the year, for 4 months, it's 123.
Mhm.
Okay, so for the year, we look good as far as cash, and cash it's fine in my opinion.
Yeah.
Okay, now go down over that. Look at the insurance over 90 days. It's supposed to be 15, it's 36. It's more than
Wow.
double. The Medicaid is 33. What the goal is 20. This one really throws me.
Trying to figure that out.
That's the Medicare advance.
Advance.
Because we got Medicare advance of 6 months.
That
But
explains it.
when you calculate it out for the money,
It's already
you're going
in.
to come to a big negative.
Right. Got it.
The registration accuracy is good. The denials are about double, as you can see that for the current month, and also about double for the year to date. If you go down to the current month for rebills, you can see that's about right, but we have rebills year to date of 3 times or 4 times, 3 times anyway, of what it should be. And that was us not being able to use the RCM services as well as we thought we would be able to, number one. And number two, we've had a miscoding in the Medi-Cal, which has always been the problem. Even as it relates to the SNF, that's one of the problems in the SNF. And we're finding those. And I'll bet you in the month of November, our biller basically for SNF actually had, I want to say, just charges over $500,000 that were coded incorrectly in the system. And I don't know why, but it was coded incorrectly in the system. Right, Barbara?
Yes. She's also had some problems with TARs on older things. Because
charge?
TARs, the treatment authorizations, having a TAR approved for the SNF patients, especially when they've been going back and forth between acute with the COVID situation.
Between acute and SNF, you mean?
Yes. If they go past
Make sure we get those dates. Make sure we get those days corrected, because there'll be a real problem in our cost reporting if we don't.
Yeah.
I know.
Right now, nothing is normal.
Right.
They're closing
Right.
down entire departments, just like Alta One closed a whole damn store down.
Yeah.
And it's sort of crazy. And so things are just not normal right now. So you can
We
guess
also
and
have
try to
one
figure it
new,
out.
we also have one new biller that's been learning and doing a good job learning. We had another one leave, so we're looking for a replacement right now. So that makes us a little bit short too in staff.
Thanks for the explanation. That explains it all.
Working really hard on it, but
I know. Appreciate that too.
the next page is page 24, which is the cash collections for the month. We started with 1,700,000. We collected 2,911,000. And like Chet said, some of the extra collections in the miscellaneous cash, at 800,000 for the prime. We also received a $175,000 check from Kern family due to the COVID. Some taxes and a donation from the auxiliaries in that amount.
Was that the money that they were putting out for the rural health clinic for the COVID help from Current Health Systems? There was 175,000, I think, that they were going to put out there. We had three things we had to do.
That's probably what it is, because it was COVID related. I don't remember if it was strict, it was RHC.
I think that's the thing that they gave us. There was an advance on that.
Yeah, I think it is. I think you're right, Tim.
Okay, thank you.
And that's contingent as well on them doing some work for wellness from Current Health Systems patients. They have to actually meet us. There's some certain criteria because the money's beginning to be related to pay for performance. So that wellness portion, they have to report. And I've always asked Greg if he can do that. And we've actually signed amendments to our contract with Current Health Systems that require those wellness actions. So they not only part of their positive aspect is actually not only the money, but they're actually, in addition to seeing all those patients, they're doing those wellness visits and procedures.
Right.
They are really cracking it.
Yeah, which will help us. That was one of the strategic objectives, obviously. So that's great that they're working on that.
Okay, the next item is the total expenses, and we paid out $3,300,000 this month in payments. And with our with our reserve accounts, we ended the month with $2,529,000. Salaries are up in the month of October because there were 3 paydays. So
that's why you can see the over 100%
Yep.
of the collections. You can see what it does. This is the cash side.
Yeah.
If there's no other questions, on page 26, your debt service ratio page, the calculation that our Cal Mortgage requires us to calculate each month. The debt service ratio currently is 0.14 of the required 1.25, and the total current ratio is 0.52 of the 1.40 required.
Barbara?
Yes.
For your information, while you're on this page, I don't anticipate from the new revenue bonds, if they go through, having the number of covenants that we have here, but I would like, if the board doesn't mind, us to keep applying that new money because the old will be gone away. But let's use those same criteria for the covenants, even though they're not really in the, you know what I'm saying?
You keep tracking, you mean?
Keep the same targets.
Yeah.
Okay.
Oh, Chet, are you saying trying to keep the ratios the same target? Is that what you're saying? Just for clarification.
Yeah, I think that's what he was saying. That's the way I took it.
Tracking it in the same format, I think, is what he's saying.
Oh,
Yeah.
okay. Okay. I see.
So if there's no more questions, on page 27, again, that's another Cal Mortgage page where we're required to fund a certain amount of capital annually. Currently, we've recorded $38,371. And at the bottom of the page, we have the record of payments that are due. In February, the interest payment will be due of $38,000, and you can see we have $39,000 in the fund right now to cover that payment.
Which is enough to pay the interest in
Interest.
February.
Because everything's principal now, right?
Probably before, and about by then we should have paid this off. I think they're figuring the funding somewhere the first part of February. And so if that happens, this will all be gone and new money will be in there.
Right.
So
Okay.
you want to start looking at that in January, Barbara? I don't know exactly when that'll happen, but I think they're figuring February.
And the next page is checks.
Yeah, it is. So I'm gonna try to show you from this, what departments, when we lost $300,000, did well, and what departments didn't do well, and why. Let's start with, right to the left, we have Med-Surg. You can see that they lost $148,000 for the month. And let's go back and their budget was 35 or 36 positive. Let's figure out why. First thing you see is the utilization off, and this actually includes all the inpatient, 170 days versus 194. So you can see what that did to the revenue, about 300,000 if you want to look at it that way. In revenue, the deductions as a percentage were a little bit less than they usually are when your revenue's down a little bit because of the per diem that gets paid. So it's down about 400 versus 500, not quite 400 versus 500. So we're talking about 100,000 net collectible in revenue. Then you go to the expenses, and what you find is the expenses were actually over budget, even though the volume was down. That's the part of the thing that bothers when I get real upset about that. That's why. And let's see where that was. Where it is first in labor. You can see it's about $50,000 over our budget, which actually was based upon a higher number. And then you can see the supplies, which is about right. It was down a little bit under. Then you see the other expenses, which is, I would have to look and tell you exactly what it is, but it's not related directly, dollar for dollar to revenue. But there's nothing that I know of that was super extra necessary. It's just spending money on and spending money on salaries when you probably, in some cases, the salaries you have to because you're going to hit minimum staffing. Okay, so I'm not as concerned about the salaries of $50,000, but that $12,000 versus $1,200, that one really bothers me.
Do you have any detail on it?
That's the other costs.
No, I know, but do we know what it is?
I don't know it right now. Barbara
Okay.
can tell you that. Barbara, can you check what went under other?
Yeah, if you could just shoot mark that.
Let me just look at my detail for a second. I got the detail here.
You got it, that would help.
Medical, surgical, other costs. I've got purchase services, 176. Depreciation, 3,374.
Just 2,000.
Rents, here's a biggie. Here's a biggie, rents and leases. I don't know what we were renting, but 7,472. Other ones are small. Utilities, 273. Telephone, 79. And
Hey, Chad, go back to the 3,000 one.
Pardon me?
The one for $3,000. What was that one? The second or third one you said?
The $3,000, that was depreciation.
Appreciation, yeah.
So why is that so much more than the budgeted 1,270? If
Because
we
the things
anticipate,
but it wasn't more than the budget, the 3,000, it was 3,171 is the budget for that. If you want to talk a line item.
Well, no, you're just looking at the
that
budget for,
under
the
other.
budget for
Overall,
was only
The
1,200.
biggest one is the rents and leases, although it wasn't that big versus the other. You have, okay, I'll tell you what they are.
But
salaries was $8,000 over, over. Benefits was $9,000 over.
Wow.
Physician fees were $2,500 over. Here's the biggie. Registry was $27,000 over. $27,000. What that means is you had salaries that would normal amount you were covering in salaries, plus you used registry on top of that. So effectively, some of that, yes, can be minimum staffing, but like the benefits of $9,000, almost $10,000, no way in the world. That's 10,000 over. No way in the world that has to do with minimum staffing, because the benefits are the same.
let's
So-
let's look at that offline.
Not,
I'd like to know more.
not controlling labor is the biggest problem. I said that before, and that's how that.
And again, there's only so much they can do, Chet, like you said, when they get down to minimum staffing. Our census was low.
Minimum staffing, yes.
Yeah.
Benefits, $10,000, Tim. No.
Yeah, we need to understand what's in
I
there.
can tell you what I believe that was. It was,
What?
I believe you're letting people off because their kids aren't out of school for COVID. And so you use registry instead of using those people. And you let them take.
That is
Absolutely false.
not true at all.
That's false. You can believe it all you want, Chad. That's false.
Barbara, can you look at the detail on the paid salaries and find out why we had that? Can you look at people that had,
Yeah, let's take that offline and let's look at that. I'd like to know more about it.
okay?
Thanks.
So let's go on. For the year to date, they were 415,000 loss. Okay, and I'm not gonna go into that again, just a month. SNF, you see that they were actually under in volume, which they have been. You can see that interestingly, it didn't do that much in revenue generation. Revenue generation was pretty good. That really has to do with what supplies they use more than anything else. Not so much the ancillaries, because they're outpatient, but basically it has to do with just the charges that you had and the in the supplies and stuff. The percentages, you can see that the percentages was a little bit higher in deductions. That's the mix of the patients. We're having more pretty much patients that are, what I want to say, hospice, yeah, or hospice related patients, which actually carries a different rate than the other. If you go down to salaries, they did a really pretty good job on their salaries. You can see, even though they were under budget in volume, they tried. They really do try to flex there. You can see the 233 versus 282. You can see that supplies, it's under, which it should be because they're lower in volume. You can see in the other, it's pretty close on. So they didn't have any other expenses over. So you can go down and see that the gross profit actually was they had almost made up to what their budget was. Then you go to the overhead, which actually follows the actual expenses. And they, instead of losing 25,000, and this is with lower volume in a month where we lost 300,000, they made 48. Now that's, let me say, we'd like to have more volume there, but they're managing pretty well. Okay. Now the ED, and the ED is kind of again, look at the volume, it's way down. Look at the revenue, it's down. Look at these salaries, they're actually up, kind of like the other. And I know that they're more fixed in that area because you don't know what's coming in. You really don't know. And you've got to keep that somewhat reasonable. And it's not dramatic, the difference, but basically that's good. You look at the supplies. Their supplies were a little high, but I don't know that I have a problem with that. It depends on the nature of the supplies. Their other costs were down fairly substantially. So they had a gross profit of 42 versus 509. They made up for what they were going to do by quite a bit. And so the overhead costs followed that. And actually, instead of making 358,000, they made 342. Okay, so they managed well, even though their volume was down. Let's go to the rural health clinic. The rural health clinic, you can see how much they're up. They had 2014 visits, 1,500 was their budget. You can see what that did with the revenue, fairly substantially up. Even though what that made up because of the intensity of service over there, their contractuals are actually a little higher than what we had budgeted. So as a net basis from that, we actually had 423,000 collectible versus 428. So even though they had the volume, it's a bit, depends on the mix of patients in there and the intensity of service. If you go down to And one of the reasons for that also is that we don't count the COVID in that total because it's counted in outpatient, but it has an impact on what happens over there as well. The labor and fees, you can see they were under in that, okay? And the interesting part about this is that they have pretty consistently been that way in controlling their labor rates, and they were pretty good about having volume increases and not having lower in their, not having to go up in their salaries. But you can see the supplies, okay? So they're a little bit up, which they should be because of the number of visits. We get down to the portion of gross profit. They're at 192 versus 199 in the target. And you can see then overhead follows that, so 50 and 50. And so they made 141,000 versus 148 of their budget. So again, good management and with volume, even though the volume's up a little bit higher. Now, surgical, you can see they really had the best number. They were actually above budget. I can tell you exactly how many procedures. I think it was 9 procedures above budget for surgeries, which includes both surgery and endoscopy. So you could see how the revenue went up, 309,000. Their contractual allowance was just slightly higher, even though they were up in volume. And then they had labor. Okay, the labor you can see was up. I don't know. Yes, we had a few more surgeries, but I'm not sure. I think all of these were still scheduled surgeries. Because I don't really see any, and we really don't do any emergency procedures. So it was just they used more salary expense and I don't think it's just, usually the 24,000 is just Gail and Travis, and Travis is actually not salary, but it's in the labor. Okay, their supplies you can see were slightly higher, which makes sense. Their other costs are a little bit lower, which is great. You can see their gross profit then was 85,000 versus 69. So they managed actually pretty well. You get down to the overhead expenses. You can see how much higher that is than the budget. We're trying to keep that in place, but it will follow expense to some degree, but what's coming out of the cost report is still going to throw a certain amount of money in there, because that's what we use for step-down allocation. And I really felt kind of bad that they lost. We had actually budgeted them for a loss, 97. They lost 107, which, in other words, as that comparative is better than it has been. But that fixed cost is so stinking high in that department because of the fixed costs of the building and that we're not using adequately, that it makes them look like they don't manage well, but they were managing pretty well. This is not something they could manage. Let's go to the outpatient. The outpatient, you can see, was substantially up. And this, let me say, is not necessarily coming from the ER because it was not up. It's coming from the clinic, which is what we hope that it does. We want to see more outpatients coming from clinic patients or other doctor's office patients using our services. Okay, so you can see that. At least see what it does. It didn't really create that much more revenue. And I'll tell you the reason why. Remember I said that COVID was in the outpatient? Well, COVID actually is in that number of visit procedures, whatever you want to call it. And then it doesn't carry that much revenue. It carries a volume and it carries an expense, but it doesn't carry that much revenue. Am I making sense? Okay, so basically, even though they look like they have tremendous volume increases, that's in COVID tests. Now there is some money that comes through for that. I don't want to say there isn't, there is, but it's not that dramatic to revenue. So you can see that actually for net revenue, the collectible was actually under the budget, even though the volume was above the budget. Now, again, that's because of COVID. Their labor costs, again, this carries the COVID labor, okay? So the labor cost is 52,000 versus 40 in the budget. It carries the expense and it carries the revenue, but the revenue isn't nearly what the expense is. Let me say it that way, okay? Look, but it isn't something that's actually a collectible component, because you can see the budget for the contractuals was 63,000 and the actual was only 60, okay? So that's why the expense is up. That's why they're, it's not that they didn't manage well. That's not what it is here. It is a function of the COVID and how it's impacting. And overall, what does that mean? That means they still had gross profit of 101,000 versus 123, okay, which was without the COVID. And the overhead expenses follow, even though the overhead expenses follow a higher amount of direct expenses, they still made $73,000, $74,000 instead of the 99,000 without COVID. That's what the COVID cost us, basically, was the difference between the 73 and the 99.
So you're saying that the COVID testing over across the street has cost us money?
Yes, I am. By how we're staffing it, yes, I am.
Because I was under the impression.
But based upon what we get for it, yes, it is.
Okay.
Rehab, and it would most places. That's why most of the places have stopped doing their testing, drive-through and things like that, because it's expensive.
Okay.
For the physical therapy or the rehab services, you can see they were down fairly substantially. What that did to the revenue, and so we have even the percentage is slightly higher as far as the mix of financial class. So then what you have is the salaries, which is a little bit, they actually kept their salaries under something. I'm sorry, but our previous manager did not know. Grace is now, even though her volume is less, she's keeping her salaries, her labor in line. They did not do that before. She bought a few supplies that were different than what we have used in the past. Some things she thought she needed for the patient. So the supplies are actually, I recall that, and it's a one-time thing. And it's probably okay. It's almost like minor equipment, but it's really supplies. Let's see. The overhead costs follow direct labor. And so because of the volume differences, even though they did a good job with their managing the salaries, they did have a few extra supplies. And so they broke even, instead of making $12,000, they actually broke even at $2,000. The last one is the retail pharmacy. You can see how far down, that's been down now for 3 months, I believe, under budget. And you can see what that does to the revenue. Not dramatic, but because the interesting part about that is a part of it is, even though they have lesser volume, they've done a better job of charging for their pharmaceuticals, their prescriptions. The prescriptions, I think the budget's at about $1.60 per prescription average. And I think they're up to $1.80 right now, prescription average. So you can see their revenue, net collectible revenue is 186 versus 190 in the budget. Again, they're one that does not control their staffing. They should manage the hours of the pharmacy techs a little better. They are not. You can see that the other piece of it, it's not as large this time. They did a pretty good job with their buying of pharmaceuticals. It's only about $3,000 over. So you can see that difference there. You get down to the point of where the gross revenue, 14,000 versus 30,000 in the budget. Then the overhead costs, which follow the expenses, 20 and 19. And so you get down to the very bottom, where instead of $11,000 in profit, they lost 6,380. which is a lot better than they have been doing. So that's kind of where it comes from. If you go back and look at it, let's say, in my opinion, the biggest part of it is the fixed costs in the surgery and better managing our costs in med surg. That's what it is.
The pharmacy, Chet,
Pardon me?
we should be making money in that pharmacy. We need to manage it better. And we are, Tim, aren't we gonna do something?
Actually, you're right. And what the biggest problem before was how they bought, what they were charging, number one, and that's been resolved. Secondly, what they're buying, how they're buying, that's been partially resolved. And then their staffing, which has not been resolved. So
Yeah, we're gonna look at that. Yeah, their staffing was up $10,000. I want to understand why.
Right. We could consider selling it or contracting it out. There's a lot of things you can do, but if we're not going to manage it right, we can't have a business like that and lose money. It's not possible. So we're going to deal with it though. Right? Okay, thank you.
Hey, Chet, I had a question real quick.
sure.
Just on the surgical services, or maybe it's the med surg. Refresh my memory a little bit. But so those units are in the ER wing portion of the hospital, correct? Because it's cost associated with depreciation. Is that correct?
Yeah, the depreciation is based upon square footage.
Okay. So
Okay.
so are those are those units going to be part of when we do the construction phase? Is that going to be part of that or no?
You betcha.
John.
Every time that's why I was saying, I don't remember, I think it was yesterday or the day before.
Surgery is in the newer building, the newer construction,
It is.
not in the older construction.
The med surg is in the older construction.
Yes, but surgery is in new.
Surgery is the new,
Okay.
yes. It's why it
Okay.
picked up, when we didn't
Okay.
do, I didn't know that was the question.
That
The
was-
answer is surgery right now picks up a whole lot of depreciation from that $21 million revenue bond that we have right now, that we did in 1991. So it picks up a tremendous amount of that, and that's what the problem is. But the problem, in addition to that, is it's square footage, and so all of the pre-op area, it's a very nice pre-op area, okay, in my opinion. That pre-op area is used for people sitting in desks. It has from the very beginning, as far as I can tell, where it should be actually used for patient care. In other words, we're taking something and really getting nothing, no revenue per square foot in any of the pre-op area. We're getting nothing but expense where we should have been, and we actually originally for depreciation paid for that about $1,000 per square foot in construction. So that's why you really need to be thinking about since you brought it up, when you need to be thinking about the construction we're going to have. I don't think it's going to, in the ER being the old part of the building, even though it's going to put costs in there, I think we can absorb most of those costs. You saw the profitability in the ER. We cannot, I again say, we cannot absorb additional new costs in med surg because it's just going to make it worse than it is now. We need to try to, at all possible, keep those things as they are.
To answer your question, John, the surgery department is in the 1992 building. It's not in the 1965.
That's what I said.
Okay. Yeah. I do apologize. Sometimes every time I see surgery, I conflate the two because I see surgery and I think they're both in the same department. but yes, yeah, you answered my question. I was just trying to figure out a way, when the construction starts, is there a way to?
I can tell you the difference in the depreciation. Hang on a sec. And it really isn't that's in the budget. Part of that's in the budget. I'll find the detail.
We have some ideas about changing that pre-op area. We're just trying to get them implemented. It's a slow process though, especially during COVID.
Okay. Yeah, I understand. Thank you, Mark.
Let's see, one more page. The, okay, the depreciation and amortization is $37,600. So that's the overhead, and it follows as much as possible. I think that's the biggest line. Let me look. No, it isn't. The maintenance and repairs on that department is also high. Now, it doesn't mean it isn't in the budget. It's 47,000, and the operations of plant, which means the utilities, the things of that nature, is 55,000. So, and then the housekeeping is 29,000. So those are the kind of things, because of its bare square footage based in a new building, you take those things together, there's about, I think I try to figure it, but there's about $130,000 per month in costs that come from the construction.
Okay. Well, that's a pretty good chunk of change.
Yeah, it is.
Okay, thank you, Chet. That's good information to know. I mean, I'm just trying to wrap my head around the whole thing.
No problem. Okay, let's see what we have next. I'm going to try to go through the other part fast, if I can here. You have the liability section for the last 12 years. There's nothing really, in my opinion,
29.
remarkable. That's page 29. Okay, nothing dramatically remarkable there, unless you have a question or concern. If not, I'll go to page 30. Page 30 is for the last 12 months through October. You can see that for the last 12 months through October, we have a budget of 26,000 in collections, and we've collected 37,000. There's your over 100% that we saw a while ago when we looked at the business office sheet. Okay, so it's $10,000 more than what we had budgeted. As far as our operating expense, we talked about that being over, and what was it? Well, in cash, we actually spent 32,000, and our budget was 22. So we're $3,900 over, or $3,900,000 over our budget for operations. Now, this is just operating costs. If you go down to the left-hand section, you can see that what we budgeted to go into our lathe or out of our lathe or cost us, we're about $140,000 under what we said we would have, which we haven't had to put out because of our cash position. So we put it out in, if you will, we put it out in operational disbursements rather than non-operational disbursements. But we put a lot more on top of that. The actual that we did put in, because we did have more money go into the lathe at certain points. You can see on May of last year, we put almost 307,000, and we were supposed to actually have a negative of 54. So that's the extra money we had. Remember, we had $4 million in lathe. We went to $9 million. Well, this 6 million, most of it is right there in the 3,700,000, and the month before that of 1.3. That's where we got April and May is where we got all our money from HHS, from the COVID, that kind of stuff. So that money that we got, we're able to put set aside, there it is, right there. And that's where you see that money coming in. If you look at accounts payable, we're actually about $40,000 over what we were back at the end of 2018. That's why I leave it a couple of years before I changed that. So that's that's close, because we've had the inflation all that time, and we actually paid those out. So some of the payments related to the extra money we had setting out there in operations, we still were able to fund that. On the other hand, we set current liabilities out of 2.4 million. At 2.4 million, for the most part, at this point in time, is number one, PPP is still falls into that category until we get it waived. Number 2, any of the advances from current health systems fall into that category. Number 3, the money that we got from HHS that we couldn't actually, and most of it we've actually, Barbara, is there any money left from HHS that we didn't put into income at this point?
I'm not sure. I'd have to look.
Okay, I think most of it we put into income. So mostly I think, because remember our PPP was 2 million something,
Mhm.
right? Is that correct?
Yes.
2 million something was our
2.2.
payroll protection. Yeah, so that's the biggest part of what's still out there. And that's the $2,400,000 that's in current liabilities. Okay. They have me on the next one, which is the local vendors, and I'm going to give that to Barbara because that's Barbara's.
Are there any questions on the local vendors? The total outstanding when we ran this report on 11/17 was $12,000 to the local vendors.
Is there a reason why we're paying late? I mean, when we get a bill, we should pay it normally, right? To do good business and people.
We're trying
wanna
to pay
get
them
paid.
within 30 days, but some of this is the way this report runs. Like all the current things will be anything that came in the month of
It's
November.
not serious, but
So
that the one thing, and Chet, the one thing is like we're getting bills, we're paying things like it's not related to this exactly. From the election 2 years ago, we're still paying stuff that we didn't have to pay, but we need to pay what we owe because it's looking like we owe $1 million that it's not really showing. So we need to start paying stuff up, just like Greenbaugh. We need to bring them to date. So when we pay a check, it's from past invoices. We need to pay them up to date. Now, I know this is only 30 days, but I was trying to work that in to what I'm talking about. Are you hearing me, Chet?
What's that? Say again?
Okay. Can we bring some of the accounts more up to date?
Gene, we talked about that a little bit. I talked about that a little bit yesterday, I think, with Tim. We're at 44 days in accounts payable. That is way lower than most hospitals carry it. They carry it about 60 days. So let's not pay things too quickly and break to use our cash.
I'm talking about the Elections Commission from 2 years ago. We're still not paid up to date on them. The Greenbaugh or whatever it is, Greenbaugh, it's not up to date from 2 years ago or 3 years ago. We need to keep paying stuff from old invoices.
Okay, then
Let's pay it up to date.
If we do that, Gene, you shouldn't be asking, why did we pay this?
Oh, okay.
Well, no, the bottom line is what he wants.
It's a dichotomy there.
He wants to make sure that we're paying for stuff that was done. That's the bottom line.
Yeah.
So, but I mean, the point is that they've performed the work quite some time ago and should get paid for that.
It's all history, but going forward, we should pay them what we owe them, and then pay them as they perform forward.
Right.
I'm actually, Gene, one thing I do want to wait for a little bit. I think we're okay there. I think we can increase some of it a little bit out of our reserves, okay, just to the construction. But then when you need to be aware that what it's going to do is it may have $200,000 in one check, okay, that gets paid to them. So if you see that come through, now what we're going to try to do on something like that, I would probably say to Barbara, get a board member signature on that, as well as Tim's.
Yeah, and I don't even need to know that you go that much. I think, half of that would probably be more than happy with that. You know what I'm saying? Just to get caught up so that he can get the engineers paid off for the work they've done and stuff like that. So he's more than willing to work with us on his stuff. It's the other guys that he wants to make sure get taken care of. So we can talk about that.
Okay, just
Barbara,
yes.
you have $1 million in your funded depreciation. You're sitting at approximately $2 million, right up 2 million, 2 million one in total cash in the bank. I'm talking about in West America. Take $100,000 and pay off $100,000 this next check run to Greenville.
Will that bring them?
Remember, we're all agreed now. We're all agreed now.
That would be.
No
I'm sure,
complaining. No
very well.
complaining.
I would be very appreciative of that. I can guarantee it.
That should bring them pretty much up to date, so that.
Well, not totally up to date, but it'll certainly help him pay off the engineers, because they're separate companies that flow through him. He's used up all of his reserves to keep those guys going and working for him. And so we're just trying to help him get the rest of that
But
settled
again,
down
I
and
want to
stuff
make
like
sure we don't, then when we get to the facility, the building and planning,
Yeah.
we don't complain because we're big.
No,
I want
like
everybody
I
to
said, this
agree.
is all money that's tied to that project. So
Right.
okay,
All right.
I'm good. I'm good.
That's all the questions and 30 days is not bad, but we need to be good partners in the community, and a lot of us don't have a lot of money. We work off of what we get coming in, so thank you.
We do too.
You are, and you're doing good. I remember when it was 6 months. Thank you. Okay, what's next?
The contract list, there's only a couple agreements on the list this month. AYA Healthcare, which is a registry, a nurse registry. The Hospital Council of Northern and Central California, and that's a membership. The dues are, this last year were $20,000. And Dr. Mongar, her agreement's not up for renewal, but it is for just letting you know that it's still ongoing. It doesn't need to be changed or totally addressed until 2023. And then we had two pending, Dr. Finstead's and Alta Sierra. Alta Sierra, we were waiting.
To the first.
Until after the first.
Okay.
Yeah, I'm good with Gary's going through. So
Yeah.
Did he sign?
Can I ask? I do have a
he was supposed
question
to
on
bring
this.
that back to Heidi. I don't know. Did he?
Nope.
Okay, we'll reach out to him today.
Okay. Kim, that 20,000, that's a year annually.
Yes.
Is it worth it? I know we got out of the other one, the ACHD or whatever it is.
Yeah. Yeah, this one is vital. I mean, this one, you don't want to get out of this one. So
Okay.
this one we use for everything. This is
I
your
do have
main
one question.
advocacy issue that we do. All the stuff they do for us with COVID and everything else. So this one's vital.
Yeah, Tim, they do a lot of like lobbying for us, don't they, up in Sacramento?
Big time, big time.
Okay.
I do have one question here though, and that's about the revised contract, or not, yesterday hasn't revised, but the renewed contract for Gary.
Yeah.
Finstead. We still haven't gotten that back.
We have not gotten that
Actually-
back. I spoke with him about it last week. I printed a copy and put it in his box, and he had taken it home and kind of forgotten about it. He said that he would pull it out and bring it back, but I've not seen it yet.
Yeah, and that's what he's done in the past. He just never brings it back.
Yeah, we'll get it.
Okay, so what do? Do we send it to consent agenda?
It's already been approved. We're
It's already
just
been approved.
still
now.
just pending because we're waiting for his signature.
Yeah.
Okay, all right.
We'll get
Let me
it.
tell you my concern. My biggest concern is that they disallow this for cost reimbursement because this is a Part A cost if you don't have a current contract. So it's kind of like throwing the Medicare and Medi-Cal portion of this $3,000 a month away in the garbage can because he doesn't do it on a timely basis.
We will make that known to him. Thank you.
Okay, so Alta Sierra, we're going to move forward again. Right, okay.
Yes.
So the rest of it's going to consent? Is
Yeah,
that-
I'm good with sending those contracts to consent, Gene.
All right, thanks, John. Okay.
This is Tim now for the mobile health clinic services.
Yeah, this is, again, we talked about the mobile health clinic and increasing the visits in there. This is one of the principal ways we were going to do that. This is a memorandum of understanding with the Kern Unified School District, or the Kernville Union School District, to provide healthcare services for their students and staff on their campus. And so Scott's been through this. I think everything is good here. Basically, they provide us link ups for our electrical. They provide us link ups for our internet and so forth that we can do our telemedicine on. And then we bill the patients, insurance companies, and so forth from there. So there's no fees between us and the school district. So this one we've been working on for a while, and we're ready to get started with that one.
I'll tell you one of the things, I just sent this to our cost report specialist. We're wrestling with making sure we break it out, and we are now, from the rural health clinic volume and business side.
Yeah.
Because I think we're going to be able to maximize our reimbursement, our Medicare and Medi-Cal reimbursement because of it. So we're working on that right now.
Good.
Well, the personnel are they're operating it, right? The rural health clinic, basically, so.
Well, it actually uses their license. It's considered an extension of the rural health clinic. That's the way they set it up. And that's okay, that's good.
What do we need to do? Do we need to send us consent, Tim? Or,
Yes.
okay. Is that okay?
Yeah, I'm good with saying to consent.
Okay. Then I don't see anything in here for Carrie, but I think there's something in
At the
here.
end.
Well, there's
We've
another
got one other one to do first.
ASCW
It's
supervisor.
actually a typo. That should be ACSW.
Oh,
So we got to change that throughout the document. It's Associate Clinical Social Worker.
Page is
38.
I had to double check that last night. I was looking up. There's no such thing.
38.
38.
And then, like I said, the contract basically provides, again, Lisa Wiley is going through her training. She is in process to move towards a licensed clinical social worker, which will certainly allow us to bill for her services, especially in behavioral health. In order for her to get there, she needs supervision. So Heather Berry has agreed to provide that supervision. And I believe she provides 1 hour of supervision for every 10 hours of clinical care that Lisa would provide. She reviews her charts. She consults with her to make sure that, again, she's available for crisis intervention if something happens with one of the patients that Lisa's, working with. And so she basically gets paid an hourly fee for that consult time. And so this is something we need to move forward. She's provided the service, I believe, before, Chet, hasn't she? She's provided some oversight through us as well. So Scott was involved with this one as well.
Tim, how long is it before that she has to be the supervising? I mean, what I mean is,
I wondered to myself, I can't remember, about a year, 2 years. Yeah.
I think it's 2.
It's
I
based
thought it
on
was
hours,
yeah.
I think.
Yeah, that sounds right.
2 years, right? So we'd like to see this move forward to the board so we can obviously get started with Lisa's training.
Is this
Okay.
normal and standard?
And this will only cover us, again, while Lisa is actually performing service in our clinic. So Lisa's actually going to be doing some of her training in Heather's office. We're not paying her to supervise her there, only for her supervision here while she's working for us.
And it says for 4 hours, is that per
Where you're
hour?
looking,
4 hours supervised, okay. Somebody asked, I think already, what's the number of hours we're looking at here?
the only thing I know is that when we have to do it for others, we have them kind of supervising the services. Even where we're billing for some of those things under the supervisor, it's a minimum of 20 hours per month, Gene. Minimum. Could be more, but it's a minimum of 20 hours per month.
Like I
3,000.
said, it's 1 hour per 10 hours of work performed is about the way it works out.
Okay, so how many hours does she work here a month?
For
Lisa,
us, well, she's gonna be working about halftime for us, and I think halftime for Heather, if I'm like, if I understand correctly.
32,
So about 20 for us, will be about 2 hours.
120, and then by 10, so 12 hours a month, roughly.
Yeah.
Okay, so about 1,800 or something. Do it. Okay, it looks. John, should we send a consent?
Yeah, I actually ran into Lisa not too long ago. She said she's really excited to start working on this. So I'm good with moving it to consent.
Okay. Consent.
page 42 is Carrie.
So there's a requirement that's coming starting in January 2021 that requires electronic prescribing of controlled substances to eliminate the paper pad. So that's what this whole thing is so that within our, sorry, I have a technician. Within our EHR, within this EHR, I should say, T system, which is our ED, electronic health record, they're able to prescribe these controlled substances electronically, which will meet that requirement by January 2021. There's a cost associated with this, a one-time implementation fee of $32.45, and then there's a monthly licensing fee of $216 to continue that service going. Like I said, this is a requirement. We kind of have to do this, but this is the fee associated with it. It would work by a doctor prescribing, and then there's a form of two-factor authentication so that the doctor would prove that it's himself by both his password and then a temporary password that kind of recycles and every 30 seconds or so.
Hey, Carrie, do you
Yeah.
recall if EDIS has this same capability and if it's a fee associated with that?
Yes and yes. So we have this in 2 of our EHRs already, which is CPSI, which is what you're talking about. EDIS would be kind of part of that, as well as EMD. So those 2 are already taking part in this. So yes is the answer.
So why do we have to go through T-System?
Because that's where the doctors are going to prescribe. Even if we were to not go through T-System, say we said, hey, doctors, you're going to do this through CPSI, which is possible, we would still have to pay additional licensing fees for those providers. And it
For
would,
each provider.
and it would create a much more cumbersome workflow for that provider because they'd be working in 2 systems. It would be a headache for sure, and still costly.
How long is this contract?
I believe it's a year.
We'll be paying for as long as we're using.
Well, we're set.
Right.
Yeah, this is going to be the law from here out. So
Right.
Yeah, but if they went, well, but if there's, Kim, we were talking about putting together sort of a picture of IT,
yeah,
and we haven't done that yet, but it would help us to see. There might be some other options, but
yeah.
Okay.
Yeah, for this one, even if we even in the picture, this is, regulations change and we don't really know a year from now what something's going to be. So this wouldn't have even been in the picture. I mean, we would have known that this is coming down the pipe, but not as far out as you would hope to see, just because that's just the way it works sometimes.
We get paid for, it's a service that we're doing. So whenever we do stuff like that, we get paid for it, right? So.
Well, yes and no, Gene. I think, the bottom line is, like I said, right now, a physician can write a prescription, hand it to the patient, they go to the pharmacy and get it filled. No cost to us for that. Obviously, now the requirement is you must do it electronically. That's the requirement. So you now have to do that, but we're not paying us anymore for prescriptions or anything else to do this. So This is just another one of these things where they regulate these costs back onto the hospitals. And
Well, we
it's
can-
not a darn thing we can do about
We can have it only go to our pharmacy and we'll make money that way.
it.
Well, I don't think we could do that because somebody's going to want to go somewhere else.
Okay, John, what do you think? I don't see anything.
Let me add too real quick, just in terms of the cost. Greg did some analysis when we switched the clinic up to this, and it was close to a wash in terms of cost because those pads are expensive to buy. And so without them buying those pads, and obviously the volume of prescriptions up there is higher than probably in the ER. I mean, I haven't looked at the numbers, but that's my assumption. So this will balance out some to help offset that.
Yeah, I totally have total confidence in your opinion, but it just, you know.
Carrie, can I ask, other than the $3,245 one-time fee for installation, if you or whatever, and the $216.67 per month after that, do you expect any other fees?
Related to this, no.
Okay.
That 216 per
Because
license?
it says if there's something out of scope, it's $225 per hour.
Oh, yeah,
in addition to that.
Yeah,
So you don't expect anything with that.
I don't expect that to come into play.
Okay.
Yeah, so it's $216 a month, Mark, and that covers all physicians,
All physicians, all right,
Yeah.
thank you.
which is better than other systems where we have to pay per physician. So
Per license, yeah.
Yeah.
All right.
Okay, John. It looks like.
Yeah, I'm good. I'm good with sending this to board consent.
thanks, guys.
Just one quick point. Chad just got an email from West America Bank. Apparently, the loan forgiveness documents are available for the PPP program. So I'll forward a copy of that on to you, but I got to review those and sign those and get those sent in to them. So apparently it says pending SBA review, additional notification regarding the status of your forgiveness application will occur within 90 days.
So they reviewed it already, Tim? Is that what you're saying?
Yes, apparently.
And
So
it's
the
okay
application,
there.
yeah.
We
So
just
anyway, they've prepared all the paperwork that we need to file
Okay.
through West America Bank. So they just sent that to me.
I'm also sending, and Heidi and I talked about it before you got on.
Yeah.
The West America Bank actually, for that renewal of the line of credit, they have to be annual.
Right.
And so it has to be hard. They want a hard copy application like we've done before.
Right.
I didn't have anything. They said they
Yep.
sent one to work, but it's to the hospital, but apparently it didn't come or we didn't get it. And I got one at home, last night. I'm gonna fill it out today,
Okay.
send Heidi a copy of that electronically, and then I'll send the hard copy by mail.
Okay. That's something I'll need to sign off on, or?
That's the hard copy, yes.
Okay. All right. Okay. Sounds good.
They did that quick. They have 100 or 90 days and then small business has 90 days. So it sounds like it's been fast. That's good.
Yeah. Like I said, yeah, they've got the paperwork done. Once it's submitted, then it's 90 days. We should hear something.
Right.
We also, let me say in advance, because we need the audit before the board meeting. I was asked by the auditor if that would continue to be a liability, and I said no. I believe that we were going to get it waived. So I think in the audit, that's what it'll look like, is that it will be waived.
Yeah.
Now,
Now, it's a 1% loan right now, right? Okay. Okay, is there anything else? John?
No, I don't have anything else.
Okay, that's pretty much it. Okay, meeting's adjourned.
Thank you all.
Okay, thank you.
Thank you.
You're not